No problem.
Thank you. Thank you so much. Thank you.
So
Thank
we
you.
are live now.
Yeah, we are live and we'll admit people in. So
Yeah, Dr. Vivekanand, we will be live streaming on YouTube, and
Sure.
later we'll provide the link to YouTube.
Sure, definitely.
I'll just.
Hi, Brenda.
Hello, ma'am. Good evening. Welcome. Ma'am, Harapriya ma'am is also joined us.
Yeah. Good evening, Dr. Harapriya.
Hi.
Yeah, hi, Sammy. Hello, ma'am. Good evening.
Hi. Good evening.
I was very happy to introduce Vivekanand to Down Syndrome Federation because
Thank
we've
you.
been discussing the sleep apnea for a long time. So I thought he's the right person to talk about it.
Yeah.
Many thanks to Dr. Harapriya. It's
Yes.
because of her I'm here.
Haripriya, you kept him hidden for quite some time. You could have brought him here.
Ma'am, he's a very busy practitioner, ma'am. To get him here, it's been
no
a real
longer Haripriya. He is now bound by the Down Syndrome Federation. He has no job at all but looking after our children.
Sure. I'm sure. Yeah.
So happy to have both
Hi,
of
Sammy.
you.
Good evening.
Hi. How are you, ma'am?
I'm good.
Ma'am, why are you hidden?
Not on video, but
I'll come. I'm in the middle of something. I'll join. Yeah.
Oh, okay. Sure, ma'am.
Okay, take your time.
Yeah, sure.
Parul, we can start. Sammy, we can start. Ma'am, can we start?
Yes, please.
दोस्तों नमस्ते, मैं पारुल। हमारे शनिवार के आज के सेशन में आपका स्वागत है। और मैं जानती हूँ पीछे से आवाजें आ रही हैं, शाम का खाना बनना शुरू हो गया है, लेकिन आज बहुत खुशी हो रही है हमें आप सबके साथ यहाँ बने हुए। और क्योंकि हमारी फेडरेशन की प्रेसिडेंट डॉक्टर रेखा रामाचंद्रन यहाँ पर हैं, काफ़ी दिनों बाद आज हम उनसे यहाँ मिल रहे हैं। मैम, हम आपका बहुत बहुत स्वागत करते हैं और हम आपको बता नहीं सकते कि हमारे चेहरों पर कितनी मुस्कान आ रही है आपको देखकर। बहुत शुक्रिया आपके आने के लिए।
थैंक यू पारुल।
दोस्तों, एक आज ऐसा सब्जेक्ट हम लेकर आए हैं जिस पर रेखा माँ का बहुत ध्यान है, बहुत वो हम लोगों के लिए इस पर केयर कर रही हैं, क्योंकि हमारे बहुत सारे सेल्फ एडवोकेट्स में वो प्रॉब्लम आती है जो आती है सोने में, यानी कि उन्हें स्लीप एपनिया की दिक्कत आ जाती है या सोने को बार बार उठकर बैठ जाते हैं, फिर उन्हें सांस लेने में पूरी तरीके से दिक्कतें आती हैं। हमने पिछली बार भी एक इस तरह का कार्यक्रम किया था जिसमें बहुत सारी स्लीप स्टडी और इस तरह की चीज़ों की बात की गई थी, लेकिन क्या ये आसान है? क्या ये घरों में किया जा सकता है? क्योंकि हमारे बच्चे हर समय हॉस्पिटल जाकर फैमिलियर नहीं होते हैं हर एक सिचुएशन में। तो आज इन सब चीज़ों पर बात करने के लिए हमारे साथ स्लीप एक्सपर्ट डॉक्टर विवेकानंद हैं, जिनसे हम बहुत सारे सवाल अपने पूछने वाले हैं। हमारे कार्यक्रम का फॉर्मेट वही रहेगा, मैं और समीक्षा आपको हमारे गेस्ट से मिलवाएंगे, उसके बाद उनका प्रेजेंटेशन होगा। और मैं चाहती हूँ कि अपना पेपर पेन लेकर आप अपने सवाल तैयार रखें, क्योंकि हमें समय पर कार्यक्रम को खत्म भी करना होता है और जाने से पहले हम चाहते हैं कि आपके सारे सवाल हम कवर कर लें। अब मैं अपनी दोस्त समीक्षा को बुलाती हूँ कि वो आए और डॉक्टर विवेकानंद से हमारा परिचय कराएं। समीक्षा।
Thank you, Parul. Good evening, everyone. Welcome in today's session. As Parul lightly mentioned, today's session is very important. And as parents, we do understand that given the high prevalence of sleep problems, especially obstructive sleep apnea, sleep examinations are essential for people with Down syndrome. Sleep issues can have a substantial impact on behavior, cognitive function, and physical and mental health. These studies aid in the early diagnosis and treatment of these issues. We have discussed this session many times before too, yet we feel there is more to it. So Federation has brought this session to dive deep in understanding this crucial aspect, where we will be discussing the importance of a correct sleep study, when and how it should be done, what are the signs parents must be vigilant for to take a call to visit the specialist for safe, and many more aspects related to this. this medical challenge. Today, we have with us one of Chennai's known pediatric pulmonologist and sleep specialist, and we just got to know he's very busy, and we are very grateful that he could extract time for us for this session. So Dr. Vivekanand, sir, is also a bronchoscopist and sleep medicine specialist. He has completed his MD from Karnataka, and he has subsequently done his postdoctoral fellowship in pediatric pulmonology at the Institute of Child Health in Chennai. He underwent further training in pediatric pulmonology and sleep medicine abroad at the National University Hospital of Singapore, and has also completed his European diploma in pediatric respiratory medicine. Sir has also done Indian diploma in pediatric critical care medicine. Apart from it, he has also participated in research works and various workshops, and worked in different pediatric departments and published many papers. Currently, sir is associated with Rainbow Children Hospital, Chennai. Very, very warm welcome to you, sir. And we are waiting to learn from your experience and know your experience on this crucial aspect of our children's life. And we are very, very happy that you could extract this time for us. And over to you.
Thank you very much for the nice introduction, kind introduction. And I'm very privileged and honored to be here amidst all of you. And we learned together. And if this presentation is going to create some awareness, I'm more happy at the end of the presentation. Hope my voice is clear.
Yes, sir.
Yes, ma'am. Can I share my slides?
Yes, please.
Sir, ଏଇଠି ଯୋଉ କହୁଛନ୍ତି ଭଲ
Okay. Shall I start, madam?
Yes, sir.
Yeah. So what we can do is I'll make it brief over the next 10 to 15 slides of my presentation. I'll be basically discussing about what are the sleep problems and respiratory issues in children with trisomy 21. I would just first start with the sleep problems, and then towards the fag end of the presentation, I will proceed to some of the known respiratory issues, some which are hidden, some which we need to elicit, some which are very evidently seen. So, like you all know, sleep is important for each one of us here, and particularly more so with children with trisomy 21, because many of the problems which we commonly encounter in these children are they have altered sleep pattern. Their architecture is different. That is, we are awake, we get into bed, then we enter some stage of sleep called as non-REM sleep. Non-REM sleep is for the body growth and other things, and then we enter into the REM sleep. REM sleep is for mind, memory, and etc. And then this goes into cycles throughout the night, and then we get awakened in the morning. So this sleep pattern, architectural pattern, can be altered in children with trisomy 21. They can also have frequent awakenings in the night. There might be issues of sleep onset in these children. For example, normally for anyone, when they get into bed, if they fall asleep within half an hour, it's normal. If someone takes more than an hour for sleep initiation, that is from the time the lights are off in the room till the time sleep is set in, then it's a problem of initiation. And some children also have problems of maintenance. They wake up frequently in the night due to multitude of reasons. And the most common problem, and it's a worldwide problem in children, is obstructive sleep apnea. I'll come to this, which commonly presents is snoring. The tricky thing in our children with trisomy 21 is that this snoring sometimes can be silent. Now what do I mean by that? For example, because of the facial profile associated with children with trisomy 21, so sometimes snoring may be there, snoring may not be there, and still they can have a problem. So the studies have quoted worldwide and even from our experience overseas and locally, that children have obstructive sleep apnea risk of more than 50%. And the caveat is that they can be silent. Someone with a problem can have no symptoms in the night, but still they can have that problem. So this is going on to why does it happen? What is so much into snoring and other things with regards to children of concern here? We know that children with trisomy 21 have a larger tongue. And this is one of the most important factors. Their tone is a bit flabby. So whenever the tone is flabby, it is not only for the muscles in other parts of the body, but also on the muscles of the airway and the tone of the tongue, and the muscles which are all going to be, even when we sleep, the tone is already low. So in children who have a larger tongue, and when the tone is also a part of the problem, then it tends to get exaggerated. They have small nasal passages when in comparison to other children. Low muscle tone, and sometimes as age advances, weight gain may also aggravate these symptoms. Sometimes there may be a curvature of the spine. So all these things, this is multifactorial. All these things which happen are due to a combination of factors, primarily because of all the four things which I have mentioned here. Now, we know now what is it and why does it happen. Our next thing is, what can we do? Now, what are we going to do? We know that we are going to be faced with problems during probably the first 4 to 5 years of life. That is why in the international consensus says that, particularly with the American consensus, say that all children with trisomy 21 at the age of 4, irrespective of whether they have symptoms or they don't have symptoms, they need to undergo a sleep study. I will come to what is a sleep study subsequently. This is because we need to screen early, we need to catch them early, we need to treat them early to prevent long-term effects. And why 4 years of age, even when you have no symptoms? Exactly, we can go to a previous slide, because they can be silent. They can be silent and they can cause problem. So I can request all parents who are attending this meeting here to take a snapshot of this. I will also pass it across to the group, definitely. This is a questionnaire which is called the Children's Sleep Habits Questionnaire. So this is actually a lot of things are there, around 20-25 item checklist are there. So this is freely available on the Google. Anyone can get it. We can even do translation, and it is available in English format, but we can make it translate it so that it is colloquial and easy for all to use. This is followed world over to screen in any child with sleep problems, particularly with emphasis on our area of concern here. So this is, we get to know whether the child has behavioral issues in the night, wakes up frequently, adopts particular position when sleeping, child has lot of snoring, whether child gets up from the middle of the night, whether the child sleeps excessively in the daytime, and also whether the child's executive functioning, whatever the functioning is it same? Is it getting better? Or is there any deterioration in the executive functioning because of sleep issues in particular? So this is a 20 to 25 item checklist which will help us to screen. Children's Sleep Habit Questionnaire, available freely on the internet. Now, if we have a problem, what are we going to do? Or else, when should we screen? We also follow the same protocol which is derived from the American Academy of Pediatrics. That is, all children by 4 years of age should get a sleep study. So this is the picture I have put here, is how a sleep study is being done. For example, to put it easier in words, for example, if someone has a blood infection in the blood, we do a blood test, and which is called the gold standard, to prove that is the reason your test will show what organism is it, to know what infection we have. So the gold standard test to prove a sleep problem with emphasis on what is called as obstructive sleep apnea. So sleep test is done predominantly, mainly to look into obstructive sleep apnea. The other problems which I mentioned, like they have the initiation problems in the night, or they don't get to bed, they stall their bedtime, they have the tendency to go late to bed. All these things are through sleep coaching and other things, but they don't require a sleep test. But with regards to obstructive sleep apnea, which may manifest as snoring or which can be silent, so we need to screen all children by 4 years of age, mainly due to rule out OSA. So OSA is what during breathing, what happens because of our facial features and the tone and the tongue, which is bit larger than usual. What happens is baby breathes, has obstruction during breathing. So what happens is our oxygen levels in the body dip and go up, dip and go up, and this leads to awakenings in the night time. So to pick this up and to find whether it is a mild problem, it's a moderate problem, or it's a significant severe problem, we need to do this. So what we do is we ask the child along with the parent, obviously, to come to the sleep lab. It is attended. They spend the night in the sleep lab with this, and then we have a audio video. We have some leads to see what stage of sleep the child is undergoing. We have some sensors in the nose to see how the airflow is going. We have some belts which are put in the tummy. We have some leads which are kept, and we have an oxygen sensor. So what does this do is we study through the night, and that there will be a technician who will be keenly observing the child. What is happening to the child? Did the child sleep well? Is there any disconnection in the leads, so that he can go into the room and connect the leads in case the child moves and it gets disconnected. And next day, what happens is someone who is versed in interpreting it will go, and we will put on it's an 800 to 1000 page record. So we go through the whole night study and give a interpretation to see whether there is a problem. Does that problem require treatment? If so, what treatment? So this is how a sleep study is done. There are a lot of centers in India who are versed in doing a pediatric sleep study, which is the gold standard to detect an obstructive sleep apnea, which can be silent. Like I would like to again emphasize the same. Now, people may be in rural areas, people may be in a place where there is no access to sleep test or a sleep study in a large country with billions of population like in India, unlike the Western world where the population is smaller. So what else can we do? So we don't have a sleep test. Can we screen? So obviously, yes, it is still possible. There is another thing. This is not the gold standard. That there is not the most important thing, but in the absence of something, this is a very, very important tool to screen. So what we do is we can send this small machine to the child's home along with the parent. We can ask the parent to note down what time the child has slept and what time the child got awakened. And then we interpret it, we download it into a software. It has algorithms in the computer, and manually we read and see whether the test is positive. If the test is positive, we can still give a treatment. In case the test is inconclusive, that is, we are not able to come to a conclusion. If it is negative, we still need more information. Then we can refer the child to a center where there is a sleep study or a sleep test which is available. So the pattern of how the pattern goes is we screen for a problem, ideally at 4 years of age, or anytime even before if there is concerns from the screening questionnaire, that is the children's sleep habit questionnaire. Then we ask the child to be seen by a doctor or a sleep specialist. Why we see is we just go through, is there any other sleep problems apart from an snoring or an obstructive problem. So first is the child needs to be seen by a pediatrician or a pediatric pulmonologist or a sleep specialist. Then we look into where the child is, what can be done. Sleep study is possible, or a oxygen screening test in the night in the home is possible. Depending on the locality, the feasibility, and the affordability, we come to a conclusion and choose the most appropriate test to plan the most appropriate intervention for our child. So this is, so far, this is the way how we go about it. Now, why is there hesitancy? There is hesitancy among doctors, there is hesitancy among referral colleagues, there is hesitancy among parents, and there is hesitancy with regards to all these factors which I have mentioned. Because of all these 4 important factors, lack of awareness is very important. So we need to be aware. So as doctors, it's our responsibility to spread, inculcate the message and information, how important this goes in evaluating your child, and the inputs and the benefits of it. Sometimes there may be anxiety over results. What if there is a problem for my child? We know that problems for our children with the trisomy 21 are going to be there, particularly with regards to sleep. We anticipate a problem from the screening questionnaire. That's why we do the test. So the test is being done to identify the problem so that we don't ignore the problem, and that problem can have a solution, which I will discuss subsequently. Third important thing, which is the most important thing in our law, in a huge country like ours, is availability of tests and resources. But with networking, more increasing number of sleep labs in the country, also pediatric sleep labs, and with more trained professional and with more awareness, I think availability of test resources and awareness can be definitely raised. So the hesitancy is due to, it is multifactorial. All awareness we need to inculcate, anxiousness needs to be driven away, availability and resources needs to be incorporated. So we have to work on all those things which we should work, and we are keen to work towards the same. Now, so hesitancy is one thing. So if we overcome hesitancy, what? So someone has overcome the hesitancy. We diagnose in either of those measures. It can be either a screening test, or it can be a test, the gold standard, the sleep study. Then what are we going to do? How are we going to treat? So the first thing is, we see if the problem is, I'll come from below upwards. So if the problem is only going to be mild, so if the problem is only going to be mild, sometimes we just resort to giving some nasal sprays, and then we periodically follow up the child once in 4 months, once in 5 months, and see whether a milder problem becomes a more severe problem or it stays mild. Sometimes, depending on the age, like no one size fits any child together. We cannot say this will work for all children with obstructive breathing or obstructive sleep apnea. Each child is very different. Just like all our fingers are different, the size, I mean. So we have to take a decision looking at the child and looking at the results. Sometimes the tonsils and adenoids, the tonsils is the organ which is present in our throat. It can be seen with a torch. The adenoid is something which is present behind the nose. Usually, this is the most common cause of obstructive sleep apnea in children, whoever it may be. And it could be a problem in children with trisomy 21 as well. But from our experience, from literature worldwide, what we have read and incorporated is that even if there is a problem which is going to be moderate or severe, if the tonsils is big, we subject the child, refer to our ENT colleague to consider removal of the tonsils and adenoids if the size is really big or if it's causing a lot of problem. But we have observed that even if we remove the tonsils and adenoids, 75% can still have major problems. That is the tricky thing here. So sometimes we may choose removal of the tonsils and adenoids, sometimes if we still have a problem, or if the child does not have any significant tonsils or adenoids, for example, in a bigger child, what we can do is we can support the child breathe. The child has problem only during sleep. The child snores or does not snore, has obstructive breathing only during sleep. So we can support the child breathing in the night with the help of a simple machine, which is a non-invasive machine. It is painless. We have a lot of attachments, and we fit the child and ask the child to use it and then get accustomed to it, and then this will usually for a longer term. It's for a long-term period, and we periodically do studies once in 2 years, depending on the symptoms of the child. This we are routinely used to doing even in India. Very rarely advanced procedures are done. Even with all these things, someone might still have a problem. The problem can be, in a medical term, we call it refractory or resistant to therapies. So whatever we do, then there are some surgeries which Europeans and Americans have started to do, which can be considered. But that spectrum of population with the trisomy 21 is going to be very, very small. It's only a few percentage. We will not resort to any advanced procedures in children. The selection, the percentage of them is going to be very minimal. So we have now considered how to treat. Now, long-term problems. What if we do not treat? Why are we so particular? What is the reason to be particular? Main question is, we have seen a lot of children, even with, we know that the blood supplying the vessels, you means the blood supply to the lungs, there is what is called as arteries and vessels. So the pressure in them, if we don't treat them, can go up. It is like someone is having a high blood pressure. You can simply imagine if this is untreated in the longer run, what may seem is 8 to 10 years later or 10, 20 years later, they can develop a high blood pressure, and they can develop what is known as a high blood pressure in the lungs. That means the blood vessels which is supplying the lungs, their pressure in them can go high up. So that can cause, if we don't treat it in the longer run. This is particularly with reference to the obstructive sleep apnea. There are been lot of studies on the executive functioning of children with trisomy 21. So they have found that executive functioning in children that might be altered if they don't have poor sleep quality. If the poor sleep quality could be due to a underlying obstructive sleep apnea. So these are the two this is primary, this is time and tested proven. Studies are still ongoing, but they do have a role in better sleep quality. In general, is better executive functioning. I think that is the rule with all of us, particularly for our children as well here. So these are the long-term problems. Now, this is from the International Society of Down Syndrome. So sleep is really important because it heals your body, it makes you strong, it helps you keep calm, it gives you energy. So all children should exercise in the day, turn off electronics 1 hour before bedtime, no coffee or caffeinated drinks after 6 p.m. There should be some relaxation habit before bed. Relaxation in the absence, without a gadget. Could be some nice music, soothing to the ear, a lullaby, or any calming relaxation technique. Go to sleep at the same time each night, except on weekends when all of us might have time out in the evenings. Wake up at the same time every day. Bright light exposure, sunlight exposure is mandatory for all our children. For a child, these are all Western hours. It might differ. But for a child, we need at least definitely 9 to 10 hours of sleep. For a teenager, minimum 8 hours of sleep. And an adult, definitely 7 hours of sleep. If not 8 to 9 hours of sleep, but 7, 8, and 9 is what I would go. So this is with regards to the sleep perspective. Now, what next? You're able to see my slides, man.
It's the same slides, though.
Yeah, we are at the poster you were sharing about.
Poster. You're able to see my slides now? Still not.
That poster is still there, but not after
Not
that.
moving. One second.
Yes, sir.
And share again.
Ji.
Right now? Yes, ma'am.
It's coming.
Yeah. So the next thing is now respiratory issues. So I'll go, but I'll just briefly over the next 5 minutes before I conclude.
Yeah.
I'll tell you what are all the respiratory issues which can happen here. So Obstructive sleep apnea is common. That is what we just discussed predominantly here. The next thing which I have mentioned here is these are all risks for respiratory infections in children with Down syndrome. Sometimes what can happen is the airways, the upper part of the airway and the lower part of the airway tend to collapse in children. With collapse in the sense that they are soft, because our airways are also made up of cartilages. Sometimes they can be soft. And whenever it's soft, we use a medical term called as malacia. It can be an upper airway is soft, it can be our windpipe is soft, or the part here where it divides into the lungs, right and left side, they can be soft here. So that can be a cause of recurrent respiratory infections. And most importantly, I know many of us know this better. Parents will know, all of our parents will know better. Sometimes heart diseases, if it is there, which can be associated, like we all know, there is an increased chance of recurrent respiratory tract infections. So that will be attributed. This is one part which can be ignored. Sometimes reflex. We know that we all children with swallowing or feeding difficulties needs to be addressed. So this could be a reflex. So some child is taking solids or liquids and they bring it out quickly within a few minutes or after 5 minutes. They regurgitate, they vomit, and they bring out all their contents. This is called as gastroesophageal reflex, which is also quite commonly seen. This can contribute to recurrent respiratory infections, even admissions. Obesity. We have an epidemic of obesity in our country, and I'm more concerned about our children with obesity because it adds more trouble to the trouble which you already anticipate. So a graduated general exercise regimen and screening should be anticipated here. Sometimes because of the tone, the spine can be a little curved, and this can contribute to when the spine gets curved on one side. What can happen is the lung on that side, the volume of that lung can become little smaller. So this can contribute, the capacity generally of the lung comes down a bit. So there can be an increased breathing effort, and during an infection, the child might fall very quickly ill. So this is what is called the spine problem. We call it as scoliosis. Scoliosis is nothing, just a curvature of the spine. Sometimes we can also have immune defects. So screening will be done by your specialist. So that could be a cause of recurrent respiratory infections. And I would like to particularly emphasize, this is all just like sleep is ignored. Dysphagia. Dysphagia is nothing but difficulty in swallowing. The swallowing difficulty may be due for a solids, or it may be due for a liquids. So this is called dysphagia. And if there is difficulty, what can happen is sometimes whatever needs to get into our airway, whatever needs to get into our foot pipe can enter into our windpipe. This is called as aspiration. So aspiration, because of dysphagia, is very, very common. It is also, just like sleep, this is also neglected. Now, why respiratory, last two slides before we go on to the questions. Why these things occur? Because our children with 21 trisomy have a windpipe size which is 2 millimeter narrower than corresponding other children. There can be sometimes, because of the small nasal passages and the softness in the airways, there can be some noisy breathing at birth. Structure-wise, there are some changes in the architecture of the lung. Sometimes the cells in the lungs, the deeper part of the lungs, they can have, the numbers might be a little smaller than others. There can be rarer problems, which I will not dwell here. So screening for respiratory problems once in 6 months is mandatory. Screening for sleep problems once in 6 months is mandatory. More specifically for children who have had post-cardiac surgeries. Feeding and swallowing assessment and anticipating reflex is also important. To take home, you can just note down these 9 to 10 points. Sleep problems are often missed. I request all parents to have the questionnaire. Seek help with your doctor by 4 or 5 years of age, or even earlier if you understand that there is a sleep problem from this questionnaire. Our aim is to screen. The need to screen is to help and prove the problem so that we prove and treat the problem in the most appropriate, scientific, and ethical way. We improve our quality of life of all our children, and the aim is to prevent pulmonary hypertension, which I call the pressure in the lung shouldn't go up. Sleep problems can be silent and passive in trisomy 21. That is why we mandatorily screen at 4 years of age. Pediatric respiratory and sleep training is mandatory for all children with trisomy 21. Thank you.
बहुत बहुत शुक्रिया डॉक्टर विवेकानंद और
Thank you.
थैंक यू सर। एंड हमारे वो दोस्त जो हिंदी ज़्यादा बेहतर समझते हैं उनके लिए 2 मिनट में मैं ये समरी बता देती हूँ जो डॉक्टर विवेकानंद ने अपनी पीपीटी में।
Sure.
डॉक्टर विवेकानंद बताते हैं कि अर्ली स्क्रीनिंग इसकी बहुत ज़रूरी है जो बच्चों में सोने से संबंधित दिक्कतें होती हैं, क्योंकि अमेरिकन गाइडलाइंस हैं कि 4 साल के बाद एक रूटीन चेकअप स्क्रीनिंग के लिए बच्चों का होना चाहिए जो डाउन सिंड्रोम ब्लेस्ड हैं। वो उनमें क्यों होना चाहिए? क्योंकि हो सकता है उनका ब्रोंकल एरिया नैरो होने के कारण एंड लो मसल टोन होने के कारण, इन दोनों बातों की वजह से उन्हें सांस पूरी तरीके से ना आ पा रही हो, और सांस पूरी तरीके से ना आने पर उन्हें ऑक्सीजन रात में पूरी तरीके से ना पहुंच रही हो, और इसीलिए वो शायद खराटे भी लेते हों। तो ये और इसमें इनको जो सप्लाई जाती है ब्लड की लंग्स को, वो भी उसका प्रेशर भी इंक्रीज हो सकता है, और इनमें और भी बहुत सारी दिक्कतें इसकी वजह से आ सकती हैं, जैसे कि मोटापा बढ़ सकता है बच्चों का, और उनको रेस्पिरेटरी इन्फेक्शंस जल्दी जल्दी हो सकते हैं, और खाना वापस आना रिफ्लेक्शन की जो है, या फिर हार्ट डिजीजेस भी हो सकते हैं, और स्पाइन जो थोड़ा टेढ़ा हो अगर तो लंग्स अपना प्रॉपर काम नहीं कर पाते हैं, सांस लेने में तकलीफें होती हैं। तो ये टेस्ट क्या क्या होते हैं? ईएमजी, ईईजी, ईओजी, नेजल एंड ओरोनेजल एयर फ्लो का टेस्ट, इस तरह के कई सारे टेस्ट की एक श्रृंखला होती है जो स्लीप टेस्ट के रूप में कराई जाती है। इसमें हमें ये देखना होगा कि हमने अपने बच्चों का स्लीप पूरा होना चाहिए, अगर नहीं होगा तो उसमें बहुत सारी दिक्कत आएंगी, और ज्यादा दिक्कत डाउन सिंड्रोम से ब्लेस्ड बच्चों को क्यों आती है? क्योंकि उनका जो विंड पाइप है वो बाकियों से 2 मिलीमीटर नैरो होता है, और अगर जो एक चाइल्ड की नींद होनी चाहिए 9 से 11 घंटे की, टीन एज की होनी चाहिए 8 से 10 घंटे की, और अडल्ट की होनी चाहिए 7 से 9 घंटे की, और ये मैं डाउन सिंड्रोम के संबंध में बात कर रही हूँ। तो अगर ये नींद पूरी नहीं आ रही है हमें, और नींद का मतलब एक साउंड स्लीप नहीं आ रही है, तो हमें उन चीजों पर ध्यान देना चाहिए। थैंक यू वेरी मच। आप अपने सवाल जो भी हों, अपने क्वेश्चंस डॉक्टर से पूछ सकते हैं। समीक्षा।
Yeah, thank you so much, Parul, for the translation. We needed that. Dr. Vivekanand, straight away diving the question, one of my friend has posted in the chat box. I'm reading it out for the benefit of all the audience.
Yes,
My
ma'am.
daughter had pneumonia a year back. After that, she recovered well. But now she again had spasm for which she is taking medicine. Well, just want to know if any specific tests to be done to check the condition of the lungs other than PFT. And another question related to this is that whether tonsillectomy has long-term side effect for Down syndrome children.
So I would take the second question first, madam.
Ji,
So because tonsillectomy, there is no specific long-term side effect of tonsillectomy. What only thing is that if we are proceeding for a tonsillectomy in a child with Down syndrome because of the sleep problem, we have proven the sleep problem to be quite moderate or severe, then we need to take into consideration of the underlying cardiac condition, whether the child is fit for that, what is the baseline background status of the child, what is the cardiac status, I mean, and the anesthetic considerations. But we do have done in children with Down syndrome a tonsillectomy, but we weigh the pros and cons, the other comorbidities the child has, what and all the other features the child has, I mean, with regards to the cardiac and whether there is any risk for anesthetic consideration, and we take a combined decision for the kid on an individual basis. So long-term side effects of tonsillectomy per se for Down syndrome, there isn't anything which needs to be really concerned about. With regards to the first question, child with a pneumonia, I want to know that specifically age of the child. Because
Panchal, yeah, she's there with us. Panchali, if you can share the age of the daughter. She's a teenager, I guess.
a teenager. So what is child had pneumonia a year ago. So the child had pneumonia and now she has had spasm. So spasm from what the parent mentions here, I think there is some wheezing. So definitely child needs to be the current kid whom we are discussing needs to be under respiratory specialist follow-up. We need to see the cause for the pneumonia. Is it just a one-time episode which can happen to anyone, or it is a recurrent problem? Or if there is wheezing, it's a PFT. We need to see if the pneumonia has occurred more than once, what is the X-ray status? And we discussed all those things, whether there is an airway problem is less likely to be in this age group because the child is a teenager. So we need to see whether there is any reflex, there is any wheezing problem for this child, whether there is any aspiration, silent aspiration, reflex, whether there is any feeding intolerance, or there is any aspect of a curvature. So baseline is respiratory assessment. Any pediatric respiratory specialist with this problem, they will be able to assess. PFT is one thing, like you have rightly mentioned. They will obviously screen for snoring and sleep apnea if the child has never had a screening. And X-ray, these are all baseline tests. And if the pneumonia has occurred more than one time, we need to dwell a little deeper into the kid in concern.
Yeah. So another question says that
yeah,
babies born 25th week, premature twin. One of my babies detected with Down syndrome, and he is still in hospital since 4 months. Can you advise something for the baby? Yeah.
Madam, what we can do this, I understand the gravity of the situation here.
Yeah.
The child is premature, and there is a lot of issues going for the child. See, any child born at 25 weeks, irrespective of even the child doesn't have Down syndrome, will have a stormy course.
Yeah.
So our child in concern here, I think we probably, you can email the details and other things, because it would be a very abrupt answer if I give a definite point blank answer here.
Yes.
Yeah, because there is complex issues here. Yeah.
Jyoti, it will be nice if you send the details to Brinda and she'll get in touch with you. I'm with sir and then get back to you. So the another question that the parent is trying to say, okay, there are pictures also coming of that position the parent has mentioned. She says that my daughter, after sleeping, she sits and then she puts her head towards her legs. You must be seeing the picture in the like, I mean, the child is like this. The head is on the toes, and that's how she sleeps. And that's her favorite position to sleep, she says. So can you advise something? Is it correct or?
6 years. But I'm not able to see the picture. Is it here?
Okay. Yeah. It's on the chat. Monica,
It's on the
Brinda,
chat.
can you put it?
I am trying to do that.
Yeah. Thank you, Brinda. Thank you.
Open. Yeah.
We'll try to put it like the child sits straight, legs straight, and then the head goes on the toes like this, and the child is sleeping like.
Okay.
Yeah, the picture is coming, sir. Yeah.
Picture is coming up.
Yeah.
No,
not this one.
Not this one. Wait.
Yeah.
One. Yeah. Wait 1 second.
No, actually, Doc, actually, most of them have that habit. I think they find it most convenient to sit down and put their face down, and it looks like their head is between their legs because they're hypotonic. So because of that, because of the severe hypotonia, it's very easy to bend forward.
Yes.
And I think the breathing is easier when you're forward rather than when you're lying on your back.
Correct. Like what was mentioned here, they preferentially adopt a position which the airway obstruction can be relieved.
Right.
So that is what is doing. And sometimes this specific thing here, if the child is rocked particularly to bed, there is something called a sleep onset association. Child may associate rocking position to sleep. So it's like getting used to sleeping because of a particular habit. So two things here could be the child could have a association with rocking, or they can have they're adopting a position because they're finding a difficulty when they're lying supine. So they are lying in a rocking position to relieve their airway discomfort.
Yeah, I think
Is
that's
that okay? And or do we try to stop? Because most parents try to stop the rocking, and that disturbs them even more.
Exactly. So we need to coach the parents actually to come off rocking mainly because it is what we call as sleep coaching.
Right.
Gradually get rid of that habit and adopt the position of comfort for the child.
Correct.
Secondly, most importantly, because the child is 6+ now, if the child has never had a sleep screening done, we would go by the questionnaire and whether from some form of a sleep study needs to be done in whichever way it's possible, whether to see whether there's any other underlying issues apart from this association at all.
Okay. Okay.
Yeah.
Yeah, I think that included Samik's question also. Samik,
Yeah.
did you get the answer? But otherwise, I'll read the question. This is another question, sir, which says, my son is 6+ years, sit-ups at the night and starts rocking. He sleeps in that position for some time, and then we get him to lie. That was the position we were discussing, sir.
Yeah.
The earlier question.
So
You understood.
yes, madam. Yes, same.
Yeah,
Same.
yeah.
I think same answer for the
Yeah.
same child.
Yeah.
Sure.
So
Thanks.
then he said, yeah,
Thanks.
he's then sometime then we get him to lie down, but after some time he gets back in the rocking position again. And throughout the day, he's normally active and has an hour's sleep in the
Sleep in
afternoon.
the afternoon. So
Yeah.
this is more of an feel like more of an association.
Yeah.
So we need to coach and gradually get rid of the association. And probably other thing which I've seen here is generally, children above 4 years of age, they need not have a nap in the afternoon. So usually beyond 4 years of age, we avoid any naps in the afternoon. So here could be more of an association, and we'll also screen for other issues like we discussed.
Okay. So Samik, that's also advice for you. So the next question is that my daughter is 13 years old. She has been diagnosed with OSA. Is on BiPAP machine support overnight.
Yeah.
Is it really mandatory to use the machine on daily basis?
Yeah. So from what I understand is Deepthi is 13 years old and she's been
No, my
diagnosed with
daughter, so if I can
Dipti's
say,
mother.
Yeah.
Yeah, fine. Yeah, Dipti.
Yes.
yeah, so she has been diagnosed with very low oxygen level last November, and immediately she was in ICU, and then recognized that she has OSA, and her sleep position, it has been from more than 4 years in that rocking position. We have tried all different options to bring her back to the normal, but only when we have seen this infection, that's when all these things have been identified actually. So
Correct.
now she is with BiPAP, but it is really hard using BiPAP, and in that rocking position, the machine gets torn multiple times also. And we are now worried, is it that long term we'll have to use this? Now her levels are normal, but during infection, her levels were very low. Actually.
Understand, madam. Madam, getting back to the question here is, as of now, it is definitely mandatory to use the machine in the night. But sometimes what you mentioned here is sometimes there is a lot of problems with the interface, which we call it as acclimatization. So we need to troubleshoot whether what is the position, is there any other interface which the child might benefit more of comfort. There are a lot of interfaces, sometimes like only it covers the nose, sometimes it covers the nose and face, the mouth and nose. There are some things which are like pillows. So there are a lot of options which are available for your daughter to get her the best interface. The machine is the same. It gets the best. The interface is the most important thing. So get it to adapt to her style. And regarding this is one thing which can be done. Regarding the second question is whether it's really mandatory. Child is 13 years of old. As of now, we need to use it indefinitely. But if there is a question of whether we need to use, one thing is we can do a study on any form on a night and see whether how the study is, to see whether we need to continue it longer. So that is one option which we can have. So using mandatory because of underlying conditions, because she's already been diagnosed with the OSA, is then it definitely need to use. We can adopt the interfaces depending on the adjustability of the child.
Okay. So you suggest that it is mandatory to use it?
Yes, because someone has already diagnosed with OSA. So if it is OSA, it is mandatory in the night time on a long-term basis, and we screen or reevaluate again once a year or once in 2 years, depending on the convenience and the comfort of the child.
Okay. And is there any way that we can train the kid to straight back? I am hearing that this is a problem for every kid now. So we have been trying all different options, tying her legs, tying her body towards the bed to interrupt her from getting up from the bed. But that is nothing has worked out for us actually. I'm not sure if there are any other techniques to bring her.
There are, I think if you concentrate, whether the one thing which we need to say is whether this discomfort were there before the machine was there on the child, or it was
Both.
only
Even
there
before
both.
machine and after machine, she sleeps in that ulta position.
Ulta position. So I think it is more of a comfort posture which the child is adopting. And if the time is sleeping in the bed, the hours is around 7-8 hours, and there is no other problems, then it is acceptable. It is not, and provided she is not associated to sleeping in that from a longer time. But it is more of a comfort actually. But we need to see whether the interface is also convenient for the child, whatever the child is wearing.
Thank you. Thanks.
Yeah.
Thank you.
So I think you have already answered, but still I'll read this question. My son will sit during sleep and again sleep back. This will happen many cycles full night. What should we do? I think you have already covered this part.
Yeah.
But, yeah. Then it says, hello, my baby was hospitalized for nearly 74 days due to pneumonia and sepsis, meningitis. Later, since he was not able to get over HFNC bronchoscopy, was conducted attaching report. He needed respiratory support till last week. Now we use HFNC when retractions are visible. My question is, which is the best sleep position and what all retest needs to be done, and food to be avoided, if any?
There isn't anything food, looking into the background of the kid in concern. There isn't any specific food which needs to be avoided, because this child has had a prolonged, very stormy period, almost 2.5 months in the hospital, and with a major pneumonia. We need to get back to, again, I go back to the same chart with the respiratory issues. This child has had definitely I would also know the age of the child. Someone has mentioned here. Bronchoscopy was conducted. It could be a problem in the airway, which that's why the pneumonia was so prolonged, almost 2.5 months. Okay? So this child also needs to be on respiratory support, which the child is already on. Any lateral position of sleep, a right lateral or a left lateral position, might be of comfort. And retest is sometimes whenever a bronchoscopy is done and they have identified a problem, then yearly once they will assess how severe the problem is. And this child also needs to be evaluated for is there any aspiration, any reflex, and 3 to 4 monthly follow-up with a respiratory specialist needs to be warranted here. Because the problems here could be infection due to an airway problem, and the child could also have an respiratory support because of the airway problem here.
Yeah, the picture Brinda was sharing earlier, that was the picture of this child's bronchoscopy, I guess, right, Brinda?
Yeah. So from what I
Can you
see
make out?
here,
Yes, sir.
yeah. So this child, madam, has a lot of an airway issues from the upper part to the lower part. And all the findings which are mentioned here in the bronchoscopy report are all what we usually expect in a child who has had a very stormy course. So considering all these findings, this child needs to be definitely on a 3-monthly respiratory support, 3-monthly respiratory follow-up. The support needs to be continued indefinitely, and yearly once assessment of the airway, or once in 2 years assessment of the airway, depending on the severity. Feeding, swallowing issues needs to be evaluated also for reflex simultaneously.
Yeah, thank you, sir. Sir, the question is that, is there any specific test which can be done on a yearly basis to check out a lung condition post pneumonia?
Post pneumonia.
Yeah.
So That also depends on the age of the clinical assessment.
Yeah,
is
sir.
foremost.
That girl is 14 years, about
14.
whom the parent is
14.
asking. 14 years. Yeah, you
So
answered the question of the mother earlier when we started with that question only, which has two
oh,
questions.
14.
Yeah,
14.
yeah,
Ah,
yeah,
okay,
yeah,
okay,
yeah.
madam.
Mhm.
Is there any specific test to check post pneumonia?
Yeah,
So
yeah.
pneumonia, sometimes the thing is swallowing, definitely swallowing assessment, any reflex for clinical assessment of the child, X-ray if it is warranted. Sometimes because the child is 14 years old, we can do a lung function test to assess the capacity of the lung, and you can also see whether there is the child's BMI, the weight is on the higher side. So these are all the gamut of tests which we can offer to the child
Yes.
after an examination, obviously.
Yeah. So Dr. Suman, I hope you got the answer. For that, today's X-ray he's attaching, I guess. Sir, if you can see the X-ray in chat.
Yeah. So I'm opening the
Yeah,
X-rays.
yes,
No?
yeah.
So this is the age of the child is 14 years old. No?
Yes, sir. Yeah.
So if I look at X-ray, there isn't anything remarkable here. There isn't any acute infection or nothing is remarkable in this X-ray. So 14-year-old one, then the next thing is a pulmonary function test. Definitely we can consider doing for this child. And if the lung functions are normal, saturation is okay.
SPOT 97.
Then
Yeah.
97. Then just keep the child under follow for 4 months once. And obviously, if sleep screen has never been done, definitely screen sleep for your child.
Yeah. So Dr. Suman and Panchal, you need to be vigilant about the aspects Sir has mentioned. Otherwise, everything seems okay here. So I think we are finished with the question. Rekha Ma,
I
would like to
haven't.
come to you. Yes, yeah, we would like to come to you for getting better understanding of.
We're not letting you go before we have my questions answered.
Yes.
Definitely.
We do these sleep tests at home.
Madam, a very pertinent, important question. Currently, the guidelines worldwide mentions what is that is because the pattern between an adult and a pediatric is quite different. The home sleep study, it is called as HSAT. Home sleep apnea testing is recommended worldwide for adults that is above 18 years of age. But until today, the home sleep testing is not approved for pediatrics because the information we get is less, and sometimes we miss a diagnosis, and it does not get into all our whatever we want to know. It's not complete, and it is also still not approved. I have resorted to doing it on a couple of occasions when the child is sick enough, we are able to transport the child to an hospital. We resort to doing that. That is one main thing. Or when someone is not agreeing to come to do a sleep study. So instead of doing nothing, we either offer that screening test or do a home study. But the home study is not the gold standard. It is not approved for a child less than 18 years of age, but above 18, we can recommend.
So anybody who's 18 plus can we can do it at home.
We can do it at home.
So we can recommend it, and we need the sleep labs from you, Doc. We need for you to recommend sleep labs across the country.
Definitely.
We are not able to get proper associated sleep labs because when they say come to the hospital, let me tell you honestly, the child is restless. One, because it's a new place, and the child invariably is not comfortable in a newer atmosphere. So the sleep itself is definitely distorted because of the area. One. Second, what is the cost of a sleep test?
The most important question of today's session is
only
what
my brain will think of the important things.
So I would say it is not cheap. It is. I would say it is not cheap. So hospital based or a sleep lab based level 1 study, the picture of which I put on a current scenario is anywhere between 12,500 to 15,000. So it is 12,500 to 15,000 is a single. We need a night study. So any hospital or a independent standalone sleep lab the cost ranges between either 12, I would say it is between 10 to 15,000, mostly between 12,000 to 15,000. This is the range. I don't think apart from a government hospital, the other standalone labs, this will be the cost. Second thing, a home study usually costs little lesser, probably around 7.5. The oximetry test, which I mentioned, it is a very, very useful tool, which can be used to screen whether there is a problem that the child necessarily need to come to the lab or not. So it will cost around 4 to 5,000.
So that's the preliminary test before going in for the main test.
If someone is ready for the sleep test, then we do the level 1 study.
Yeah.
If accessibility is a problem, if getting to the lab is a problem, or cost is an issue, then we resort to the oximetry test. Currently, the oximetry test I am trying to get in softwares so that the software is actually not costly. We just need a software so that to interpret it. So equipment, any hospital usually will have a pulse oximeter which is recommended for them.
Done.
And the probes is required, that is available. Only the software is one thing which we need to get into it. But it is practically possible, definitely.
So I have one very big request of you. Suppose there are 100 people, varying age groups at a conference. And we all meet, now this year we're meeting in Lucknow. Is it possible for you to do a sleep study for all of us?
For all of them, madam.
Yeah.
At
a concessional rate? And
concessional rate.
Yeah.
I can discuss the options, ma'am. I can definitely discuss the options, and I can get back to you. Whether it's
we have 3 nights. Okay, so we enter on the 12th, 13th, and 14th. 3 nights we have. Am I right?
Okay.
Yes.
So those 3 nights we can split them
Okay.
into say 25 if everybody agrees to it, and depending on the cost, because we are already it'll be like a study for you guys, and I think our research paper will also evolve from here, telling us what is it that we look for in the future.
Okay.
So I think because we have every age group there.
Okay. The study test for the 100 children, you meant the oxygen night study at home, madam, or the?
Both of them. Suppose we want the main, the real OSA test done.
Real OSA test.
Yeah.
I can get back to you regarding the feasibility of it. But only thing is, on one day, we can do
One
only
night.
for a person. One night we
night.
can do only for a person.
Well, that would be tough, no, because
Correct.
we are there,
Correct.
and also because see, my point is when you say 12 to 15,000, I don't know how many will come into that bracket.
Correct. Definitely.
That's one of the reasons why they're avoiding it.
Exactly.
Yes,
Exactly.
it is because it is not becoming cheaper for us. And any other test, I mean, we are trying to, because this is such a crucial test for us. The labs keep on hiking it up wherever we are. So this is my question. If you go to an ENT, we are running through tonsils, adenoids. It's a gambit that we have to clear before we come to the actual sleep test. Then buying the CPAP machines. Don't forget, there is also the CPAP machines.
Cost.
Those are
That's
very,
cost.
very expensive.
Exactly. Exactly.
So your department is one of the most expensive departments.
I completely do agree.
So how do we make it easier for my population?
Population is obviously, see, the problem is invariably by 4-5 years of age, it is mandatory. We do the screening questionnaire. We attempt to do the oximetry.
Okay.
If the oximetry is negative, we don't have a clue from the oximetry, then we can aim to do the sleep test.
And the oximetry, can you do it for those 100 people there? Possible?
Not on a 3-day basis, madam, because because we have it is only one machine. Software is we can incorporate not, but for one night we can only do for a patient.
So I think we'll have to leave the options open, and so
Ma'am,
Yeah.
Sorry,
Yes,
just
Brinda.
one thing. Ma'am, is it possible that sir can give us a list of
Labs.
pulmonologists or labs
That's
across
what,
the
no,
country?
no, no.
That what you asked. I'm saying where the are no 1 second. Ma'am. Where our children can get tested, and then when they come to the conference, they can have the report ready, and sir can read. I mean, give suggestions or whatever. Whoever can give suggestions.
No. If you already have a lab test done and the labs are there, they will also have the qualified specialists.
Pulmonologist, yes.
They will be giving the suggestions. You can't bring a test here and then take it back to him, because whoever is doing the sleep test will be the one who will be qualified enough to give you the suggestions after that. Am I right, sir?
Yeah,
So
yes, ma'am.
we don't have to keep going back and forth. And yes, there's a second option that sir can always read it. But as far as I know, in any part of the world, sir, they do the sleep test at home, because they find it more comfortable for the child to be in his own space. So that my question to you is, I would, when I do it once and for all, because when they're taking them to the labs, it is just not working, and you're paying the money and still coming back saying it never worked.
Subsequent, for example, if you do 100 children with Down syndrome, you might fail in 20-30%, 20-30 children, but we still have got conclusive results, madam, which is enough to interpret.
So what we'll do is, for those 100, we will fill the questionnaires.
Yes.
Understand.
We'll do the questionnaire first, because they might not understand the language and the questionnaires. We'll have somebody sit there and finish the questionnaires. Then we will have you assess it as if you can, because at least we'll have a baseline study, and we will be able to
How many are in urgent need? Triaging can be done.
Yes.
Triaging can be done.
That we can do. And we are inviting you now straight away for the conference, which is in September. So please block your dates. And we need you there as the young generation who is going to support the cause of Down syndrome. Thank you so much for your time. You're going to be bombarded with a lot of questions, and we will be in touch with you. Thank you so much.
Thank you for the opportunity. Thank you.
Yes.
Thank you so much, Dr. Vivekanand. It was a very beautifully taken PPT.
Is somebody there who's shouting, Samiksha?
Yes, Panchali, your voice is echoing. Yes, what do you want to ask?
पूछना था,
पूछो।
वो जो मशीन जो आपने दिखाया था, अगर वो हम खरीदते हैं, कॉन्फ्रेंस में लेके आते हैं, तो क्या डॉक्टर हमें हेल्प कर सकते हैं वो?
Which machine, Panchali, you're talking about?
मैं फोटो भेजूंगी।
I think she's talking about the CPAP machines.
CPAP machine?
हाँ.
So doctor, the same for the parent of the same child, we discussed 14 years of age, and you saw the X-ray also. So she's saying if we get that CPAP machine in the to you in conference, if you are there, so will you be able to guide them?
Sure, definitely.
Yeah,
we can.
That definitely.
Yes.
Yeah.
देखिए आ जाओ पंचाली, हम हैं वहाँ पे, ठीक है?
उसका प्राइस कितना होगा?
Yeah, for that you have to.
अलग-अलग प्राइस होंगे, वो आप देके आइए, वो हम बताते हैं कि आपके बच्चे के लिए ये ठीक है कि नहीं है, ठीक है?
अच्छा, जो मैंने फोटो भेजा है, तो वो
where you have sent the picture, Panchali? I can't see the picture.
Picture से तो might
we
be
can see the X-ray of your daughter.
Sammy, he might not be able to. The names are different from different.
Yes.
Okay.
Yes. Okay, sir. That picture you had shown that watch and that.
What was the question, madam? What did
she says that if we take that particular device, which is connected to the index finger, and the rest is a watch, so will it? It is. Do you advise them to buy that?
No, definitely no. It is a device which is given by us to screen in the night when someone cannot come to the lab. No one needs to get any of those. Definitely no.
Yes, Panchali, that's not to be bought.
Okay.
Venkat, you wanted to ask something quickly, if you unmute yourself, please. Unmute.
Yeah, just last one question.
Yes,
So,
Yes,
sir, my son, 6 years old, we
yes, sir.
did last year sleep study and
Yes,
it
sir.
was bad. So, we are using the
Oh,
BiPAP machine. So, now the question is, they have advised, because he is having the adenoids, they are advised to
yes,
use the meta spray before the sleep.
okay,
So,
sir.
what is the importance, how frequently we should use it? And
Uh,
also during the daytime, the usage of machine, because without the machine, sleep but in his position, but the sleep time is only 1 hour or 2 hours only in the daytime, not regularly on if he over exerted during that time. But that time I feel he is sleeping better
okay,
comparatively. He will not have more distractions. And also
okay.
the when we have to do the next to sleep study, and whatever the current mission we are using, does it have any to take the recordings, like we are already purchased a mission and we are doing it, so based on that readings, can we know whether it is improved or not?
You pointed a very important question which I didn't address here. See, sometimes what we do is when someone has got a machine and they are using it, we do actually another study. Because we have found a problem, we are treating the problem. We are giving some pressure by PAP or CPAP, we are giving a pressure. So after they use, if someone can afford it, that is the main problem here. Because we ask them to come back to the lab with a machine, sleep with the machine on and see whether whatever pressure we have set is appropriate for that child. That is called a titration study. And we say it's like giving a prescription. Your child's weight is 20 kg, what paracetamol dose should we give? So what pressure is your child require is we bring on the machine to the lab, set up, do the study overnight again, and then we give a prescription. This is the pressure you need to use for the child for the next 2 years. And then every 2 years once we take it forward to see whether it is adequate. But again, it is not feasible for practical for all, because it adds cost to one more study. But we are also resorted to doing that. That is the most ideal way to see whether what pressure is now is adequate or inadequate.
So we have to carry our own mission during the next study.
Correct. When they will do a study with the machine on in the child. But
Okay.
the labs which were done previously, sometimes the equipments are a bit different. Not many would have access to that study. So you should inquire whether they do that. It is called a titration study. It's called a titration study. So we titrate the settings by putting the machine on the child and see whether what we have kept is adequate. And we give a fixed setting for the child, which we can use it for 2 years. Because composition, the pressure varies with weight, body mass index, and other things.
And the importance of the sprays, like my son have
Sir,
little mild adenoids, so
yes, sir. Sir, any spray to me, giving it for more than 16 weeks, I will usually not give it for more than if you can try, it's a good option. But when you're already on a machine, and I don't think there is any utility in giving it for more than 3-4 months.
Correct.
Yeah.
okay,
Doc, one last question. We keep
Yes,
saying
madam.
question. Is there a portable device that you can carry when you're traveling, like just a nose bag like thing, which helps us, because they were mentioning it?
Portable sleep device, madam. Study.
Yeah.
I
Just like
can
your CPAP, there is one which you just clip onto your nose, and
correct.
they were mentioning in overseas that it is so much easier to use those. But is that practical?
It is not sometimes practical. I think what they meant is the most important thing when someone uses the machine is the interface, man.
Okay.
So there are lots of interfaces. We never use for a child who is on home this is for a long-term ventilation. This is a child who is outside the hospital. See, we never use this mask because it is claustrophobic now.
Yeah.
So there is something called nasal mask. It's a nasal pillow or a nasal gel pillow like this, which is more comfortable actually for the kid.
Okay.
Those can be carried, and we can show it pictures, or one of two I can even carry it. It's either handy, they're small to carry.
Okay. Yeah, Sammy, thank you so much. Thank you.
Yes, thank
God
you
bless
so much, Doctor. Every
Thank
moment
you.
today spent with you was worth it. It is because you are so committed to sharing your wealth of knowledge, and we hope to see you in Lucknow also during our conference. And we hope we are going to, trouble you less, because one of the doctor who came to the session, he said, "See, if your child sleeps well, I sleep well." So we really wish good sleep to you also, because doing the sleep study,
I had one last question. Can I ask it?
I think we have a
No, I
real
think we are run out
short
of time. You
yes,
write it down and send it to him, please.
yes,
Send it to
yes,
us.
Sure.
Okay.
yes. Anybody having any question, please write it down to
Right.
us, to Brinda, to any one of
I've
us.
written it, but it is not asked, so I thought I'd just.
Yeah, I think it got really late, Gauri. I'm
It's
so
got late for
sorry.
now.
I'm so
Yeah,
sorry for
that's
that.
way
Yeah.
beyond time.
Thank you so much,
Thank
Dr.
you,
Vivek.
thank you,
Thank you, Rekha ma'am.
Thank you,
Thank you,
Doc. I'll keep in
Brinda.
touch
Thank
with
you,
you.
Harapriya ma'am.
Thank you
Thank you.
so much.
Thank you so much.
Thank you.
Thank you.
Bye-bye.
Thank you so much,
Thank you.
sir. And
Thank
thank
you
everyone.
all.
And
Thank you, sir.